Dr. Deti.
Good morning.
Good morning.
Good morning. I do see Nas, and now I do see Aji on and off. Good morning. I think we are all live in the show. I don't see Dr. Detti.
Oke dok, ini saya kirimkan linknya lagi dok. Saya apa namanya?
Otherwise, I think we can start. I do see the link for Dr. Detti. Aji, do you know if Dr. Detti is coming?
Yes, he is. She is in trouble to log in, but she is now trying to come to the backstage.
Okay, I think we are on the podium already, and I think it's a good, wise idea to start. So everyone, really welcome to this meeting on maternal mortality. I'm very happy, and I will try to present and slide my I'm trying to share my slides now. Yeah, I hope everyone can see it. It's really nice that Winner Initiative did give us access to and the podium to present our work and our collaboration between. Good morning, Dr. Detti.
Hello, good afternoon, everybody. Sorry, I have trouble.
No problem. We are complete now and we are ready for minutes. So let's start. I was just introducing that we are really happy from the Indonesian side and from the Dutch side to present our work. And as you could see in the winner announcement, that one of the domains is the Sustainable Development Goals. And maternal health is into this site and this area. And as you can see here, this is actually a picture of Suriname, of the university building in Paramaribo, where I have been last week. And they pictured it out what we all have to do in the scientific world to work on to get a better health and a better planet, I would say. And for maternal health, we are under the Sustainable Development Goal number 3 and also number 5, which is about achieve gender equality and empower all women and girls. And as you will hear from us, maternal mortality can show us where we can improve our health for mothers and babies and the families. I would like to give the word to Dr. Detti Siti Nurdiata. She's from the Department of Obstetrics and Gynecology Medical Faculty of Nursing and Public Health of the University's Gadjah Mada, and a member of the Maternal Death Review Committee in the region of Yogyakarta in Indonesia. And she will start off with telling us how the committee does work. Dr. Detti, the floor is yours.
Okay, thank you, Kitty. So I would like to ask the committee to share my slide. Is it okay? Oh, or is it better that me to share the slide?
Yeah, you can try to show the slide, Dr.
Okay.
Detti. I asked the organizer to prepared for you as well, in case.
Okay, can you see my slide?
Yes, we can.
Okay, so I will present the maternal mortality and also the maternal death audit in Indonesia. So, how to put the next slide? Okay, so this is the maternal mortality in Indonesia based on our survey in 2015. It's about 305. So if we look at the number, it's getting high compared to the 2007. So we work hard to reduce this number actually, but we still failed actually, as we can see in the next slide. Yeah. So most of the problem is occurred in our country. For example, the preparation in the preconception stage. The coverage of health examination for the bride to be is only 20%, and the coverage of modern contraception is about 57%, and the coverage of postpartum contraception is about 23%. And even the teenage marriage and teenage pregnancy is still high, is still a problem in our country. And yeah, and based on the maternal death review at 11 district hospital and one private hospital by a mass program in 2019, about 90% actually there was no delay in seeking care for delivery, but about 76% had to be referred to the other health facility, and 31% were delayed in referral process. And only 9% mother had appropriate pre-referral stabilization of the condition. And there are still such a big number of villages that has limited access to the hospital in our country. And another problem, which next, is the pregnant woman with high risk factors is quite high also. For example, here the pregnant woman with anemia in 2018 is around almost 50%, and around 30% had hypertension disorders, and 17% has a chronic energy deficiency, and about 28% has a risk of having other complication. Next. And about the quality of antenatal care, based on our survey in 2016, it's only 2.7% had complete antenatal care measurement. For example, the measurement of blood pressure, and also for blood examination. Yeah, even the hemoglobin examination is only less than 50%. Next. And based on our maternal perinatal death notification in 2021, it's the number of maternal death is increased compared to the 5 years before. So I think this is because some of them because of the COVID-19. We will see in the next slide. But if we compare to the 2016 until 2020, it's getting it's almost the same. Yeah, from more than 400 maternal deaths. This is the actual number. It's not the maternal mortality rate. Yeah, and the Java Island is the most populated island is contribute the big number to the maternal death in Indonesia. So this is Java, East Java, and then West Java and Central Java is the biggest contributor to the maternal death. Next. So this is the 10th district or city with highest maternal death. So as we can see, all of them are in Java Island. Yeah. Next. And the major hospital that contributed to the maternal death report at the 10th district city is Karawang, Tangerang, Bogor, and all of them are in Java Island. And the maternal death in other hospital may be higher compared to the hospital that make the report to the maternal death notification. Next. The cause and place of a maternal death, as you can see here, is about 40% in 2021 is because of the COVID-19, yeah, followed by postpartum hemorrhage and preeclampsia and eclampsia. It's about 17%. And place of death, 80%, most of them death in the hospital. Next. So the characteristic of the mother is about the age. It's most of them are in the period age. The golden period age is about 20 to 35 years old, and most of them death in the third trimester, and the parity I think is almost equal. Yeah, from the first parity, second, and also third parity. And most of the death occurred in the postpartum period, yeah, in the puerperium period. Next. And since 2020, the Ministry of Health had selected some district or city for the acceleration of the program to reduce the maternal and neonatal death. And right now, we already included about 2,200 district and city. Next. And this is the intervention strategies to decrease the maternal and neonatal death. So it's include the giving more access for maternal and neonatal health, and also the development or the increase the quality of care for mother and child. And of course, we also strengthening the system, the system itself, the health system for mother and child health. And the fourth intervention is how to improve the community involvement in reducing the maternal and neonatal death. Next. So the maternal death audit in Indonesia has been implemented since 1994, and the national guideline adopting the confidential inquiry into maternal death was implemented in 2010 and revised in 2015. So within this guideline, we asked the district office to reporting maternal and perinatal death, and also implementation of death review, and of course the action recommendation as a social accountability to the local government. And in 2016, the Ministry of Health initiated more proactive maternal death surveillance and launched a revised guideline by improving the identification and reporting of maternal death. Since then, we use the maternal perinatal death notification, which allows the health facility to report maternal death immediately. Next. So the maternal perinatal audit team in district and city consists of 3 groups. First, in the management group or management team, the head of health district office is responsible for the maternal death review in the area, coordinated by the head of maternal and child health unit in the district office. And the secretary is the staff of maternal and child health unit. And the reviewer team consists of internal reviewer and also external reviewer. The internal reviewer usually is the expert from the district, which will develop the recommendation and the local guideline if needed. And the external reviewer consists of the expert from universities or other district. Their duty is to give advice and also the evidence-based practice needed to solve the problems. And the third team is the community of care, consists of public and also the health personnels and health facilities who provide the care for the mother and child, and also the policy decision maker. Next. So this is the maternal and perinatal death surveillance and response cycle. So first, that the primary healthcare and or any health facilities should make the report using our MPDN system. This is the online system. So the primary healthcare and health district office will receive the maternal death notification from the MPDN. And based on this notification, the maternal verbal autopsy will be performed by the primary healthcare, and they will develop the report through the online system. Yeah, and when it finishes, so the district office will ask people who involved in the case to come and then discuss together. It is we call the maternal death review. So the cause of death will be discussed and then conclude with diagnosed based on the ICD-10. Based on the maternal death review, we develop the recommendation and also the response. And of course, we will follow up the recommendation. But the challenges in the practice in the field that not all health facility report all maternal death cases. And the maternal death is not routinely reviewed at health facilities, especially in the 2021, because of the high number of maternal deaths due to the COVID-19. And not all district or city has maternal death reviewer team and maternal death review agenda. And sometimes the recommendation is not always specific and no follow-up. Yeah. Next. Based on the study recently, there are still some challenges for district audit committee to develop appropriate recommendation and action plan. It involves the non-informative audit tools provide unreliable data for review and unstandardized clinical indicators and the practice of sharp downward and blunt upward. The third is unaccountable hospital support and lack of leadership commitment. And there's still blaming culture, minimal training, and insufficient maternal death audit committee skills. Next. So the district audit committee tended to associate maternal death in lower and higher level health facilities with mismanagement and unavoidable cause respectively. And this unfavorable culture discourages transparency and prevent continuing improvement, leading to failure in addressing maternal death local avoidable factors. Next. So productive maternal death audit is required, of course, to provide an evidence-based recommendation, and a strong partnership between the key hospital decision makers and district health officer is needed for quality evidence-based policy making and adaptive practice to prevent maternal death. Next. We developed an electronic implementation of maternal death review, but it's still under construction. We have already make some trials. Yeah. So this we called empathy is a potential to serve as the basis for formulating evidence-based recommendation related to preventable maternal mortality. So we hope that this instrument can be the basis for district level MDR and applied in research to develop intervention for reducing maternal mortality based on region-specific problems in the future. Thank you.
Thank you so much, Dr. Detti. Very interesting work, and I think we can discuss at the end some of the pieces you're doing in Indonesia. It's also very impressive how high the maternal mortality rate became during the COVID pandemic, and I think there can be some questions, but I have to see on the comment section. Oh, look, there are different ones. Is there one? I don't see a special one at the moment. No. So then I can introduce myself, I think. My name is Kitty Bloemkamp. I'm a professor of obstetrics, especially maternal health at the University Medical Center in Utrecht, the Netherlands. And I'm the chair of the Maternal Death Review Committee in the Netherlands, as well as the NETOS. And I will explain a little bit about the NETOS, which is the registration system for the maternal mortality and maternal morbidity in the Netherlands. And that's also a system which is performed in different countries all over the world, and where we do liaise together and share our results to learn from each other. But now I'm going to try to share my slides from let me see. Yeah, I hope you can see the slides. On the right side, you can see the entrance of the hospital I'm working, which is the WKZ, which is the children's hospital, which is liaised to the UMC. And on the left side is where we are talking about, which is a very devastating thing, I would say, for the mother itself, but also for the family and the children who are left behind very often. As you can see here, I like this picture because it's really showing where maternal mortality and perinatal mortality is mostly situated. And that's not in the high-income countries. It is more in the low and middle-income countries. And at the same time, you see there's a correlation or association with the numbers of physicians who are working there, which is especially in sub-Saharan Africa. It's inverse relation, and which is the same for wealth. And that's something we have to realize. Some things is difficult to have influence on, but I think as we are here together with both members of the maternal death review committees from both countries, I think there are things you can improve, and Dr. Detti already showed some hints to it. What's the history, I would say, of the confidential inquiry into maternal death? It did start actually in the UK, and they have a very long tradition. In the 1950s, they already started, and they have every year or every 3 years, they have really a nice report on all their maternal deaths and their lessons which can be learned. In the Netherlands, we did start in 1981. Then the Audit Committee Maternal Death was installed. In 2010, we did start with a perinatal audit, which was first only about all the babies who died during labor and the fresh stillborns. But now it's also that you are allowed to do maternal mortality, to audit that as well. And that is with, I would say, the whole audience is existing of midwife, nurses, residents, and obstetricians and gynecologists and other healthcare workers. So it's an external death review, but that's not yet on a routine base. And for the perinatal deaths for the babies, it's you are obliged to do it, not yet for the maternal deaths, but every 3 years we have a maternal morbidity subject of it, and in it as well, which is at the moment, I think, the peripartum hysterectomy. In 2013, the NETOS was installed, which is the registration system for maternal mortality and morbidity. And in 2015, we changed our name from Maternal Death Review Committee up to also including the Audit Committee for Maternal Mortality and Morbidity. And that's also, and I will show that later, because the maternal mortality rate is coming down in the Netherlands and is very low. And then you can learn more from the morbidity. Here you see some really nice, I think, PhDs, which have been done on all the work of the maternal mortality and morbidity in the Netherlands. And also one of our speakers today from Holland, he will defend his thesis next year on maternal mortality. And Aji from Indonesia will defend, but that will take a little bit more time. He's a PhD fellow at the UMCU, and he's working also on maternal mortality in Indonesia. This is the way, and it's a little bit the same as Dr. Detti showed in the MDSR cycle, in the way how we do work. So it does start with data collection, maternal deaths, but also the near miss and perinatal deaths. Then what you do need is a no blame culture, no blame and shame, because as you can understand, when maternal deaths are involved, it's very much the question, why did it happen? And you can only review in your committee when there's no blame and shame. And the other thing in the Netherlands, what we have is that because the numbers are so low, we have to deal with our privacy regulations, because it's not allowed to show anything which you can redirect to the patient itself. So we can't write a real report on it because the numbers are below 5. And then you can redirect and even know maybe who the patient has been. The other thing is, when you sit down with audit, what you do need in your team is more professionals from every, I would say, you need the obstetricians, you need the midwives. So at the moment in our committee, we have, I think at the moment, 5 obstetricians. We do have residents in obstetrics and gynecology in it, and we have a midwife, and we have an anesthetist in the committee. And we are in the process that at the time that we have a special case, like a psychiatric case, like suicide, that we could consult a psychiatrist into our committee. So we do the internal, I would say, internal review, which is in a small expert committee, but now and then, but not on a regular basis, it's done also by external audit, where the whole healthcare givers who are also involved in the care of the women do an audit and in a systematic way. After that, the cycle shows that you can do the data analysis, and in this way you can show the lessons you have learned, and you will see it more from the next speakers. And from that, you can, the lessons learned, you can implement in like training or guidelines. And for the guidelines, I have to say, I think in the Netherlands, the last years during the pandemic, we did a good job, because we had for the morbidity from the COVID, we did have a registration of all the COVID positive women admitted to the hospital. And it was a real-time registration through the NETOS. And over there, we could see what's going on, and the lessons learned, we could implement them directly into the Dutch guidelines. And there was a working committee on COVID in pregnancy, which did adapt our advices. So, and then there's research, and as you already heard, there are PhD fellows, and I think that's one of the ways to go forward, is that you ask young people to analyze your data and to really go into depth why women die, because you can learn from every case how sad it is. And then you have the objectives, the outcome validation, and then you go and you continue in the cycle. This is a way how the UCOS is showing their reports. And as I said, in the Netherlands, it's more difficult to write down all the cases. So you really have to show only aggregate data. And this is about the NETOS. And the NETOS is that in the Netherlands at that time, almost 100 Dutch hospitals, they agree to participate. They get, it's very easy, they get every month a mail, and in that mail, and that's the hospital representative, there we do ask, did you have a case of maternal death? Yes or no? Did you have and that's depending on what type of maternal mortality cases we are collecting, but like uterine rupture, severe PPH, or peripartum hysterectomy, or amniotic fluid embolism. And there's also a thick box that there's nothing happened. And so we really can see, and then we can go back and go into the depth of the files. And it's all in a protected system, and only the members of the committee can see the files. And when there's a researcher, we really have to ask if they can do it. And this registration system is now running under the umbrella of Perinet, and that's our perinatal registry system at the moment. But it's on a voluntary base. So there will be always some under-reporting, but we did show that this system does pick up more events than does our national vital statistics, the CBS. And for a long time, we were not allowed to do capture and recapture with the vital statistics Netherlands, but we are working on to get that going again. Here you can see, so we did collect cardiac arrest, eclampsia, amniotic fluid embolism, and at the end we have inside, we can look into the whole notes of the patients. So the maternal deaths in the Netherlands in 2013 and 20, NAS, which is short for Athanasios Kalianidis. I love this name, but that's why we say NAS. He will show the results because that's the work of his PhD. But in short, you can see our numbers are much, much lower than in Indonesia. So we are lucky. We have 6.2 women who die per 100,000 live births. And our top 3 causes of death is changing. And now in the top 3, it's cardiac disease. it's hypertensive disorders and thromboembolism. But still, with these low numbers, we do see improbable factors in almost half of the cases. Another thing is that we do see that women from a background from Suriname and the Dutch Antilles, they are overrepresented in maternal deaths, as are the teenage mothers and the older women. And the other thing is that you have to realize that some cases are not avoidable, and they can happen also when there's uncomplicated medical history. So it's not always that there is an underlying disease. So, as I said, it should not go only about registration. Don't fear audit, but you really need to have a no blame and shame culture. So you should not, as a committee, go back like, you have done this wrong, because then it doesn't work, and then people don't notify their cases anymore. This is not the way how it should be. It's really interactive, and different disciplines should be representative. And especially, I think, the midwives also, because, and probably that's the case in Indonesia as well, because they do most of the deliveries, and it's not the doctors. And this is what I wanted to say about the introduction about the Dutch system. So thank you for your attention. And I think next, then if there are no questions at the moment in the comments, so that's for the audience. If there are any questions, please do put them in the chat box. I do see there's somebody wants to have the presentation, and I think you can look them back through Winner, but we are also happy to share our presentations, I think, but then in a PDF. Okay, good. Then I wanted to, and then I stop my presentation. I think I did stop. Then I would like to give the word to Aji, but Aji is short for MMRs. I do pronounce it wrong again. Do me help me out. As I said, he's based in Yogyakarta, and that's a large region, as I understand, from Indonesia. But I hope we can. I did meet Aji live because he went to Utrecht, but it would be good, I think, that the death review committees would see each other, even live in either Indonesia or in the Netherlands, to learn from each other. But Aji at the present is a PhD fellow and is having his Global Health Fellowship from the UMC Utrecht and working on maternal mortality. But he was based at the Universitas Gadjah Mada in Yogyakarta, and he had done his master in epidemiology already. So the floor is yours, Aji.
Okay, thank you so much, Prof. Blumenkamp. Hi, everyone. Good afternoon or good morning in the Netherlands. Thank you so much for having me. And first, maybe I will introduce myself a bit. My name is M. Shairaji. It's a bit difficult to pronounce it. Everyone has wrong pronounced it, but that's okay. But you can call me Aji. And in this time, I will present my ongoing research with title Trends and Causes of Maternal Mortality in Indonesia. That's a thematic review. And the theme of this study is my PhD team me, Prof. Kitty Blumenkamp as my supervisor, Kim Brisurian, and Dr. Deti Nurdiati as my home supervisor. Next. Okay, we are going to the background. As you know, maternal mortality is one of the important indicators that could describe the quality of healthcare in certain country or certain area. And if we talk about Indonesia, Indonesia is a big country. It consists thousands of islands, and it is the fourth largest population in the world. And for the maternal mortality itself, according to the data from WHO in 2017, the MMR in Indonesia is the third highest among the Southeast Asia country. And as you know, the United Nations has a target in the SDGs point 3 to reduce the maternal mortality globally to less than 70 deaths per 100,000 live births in 2030. And to achieve that, the WHO recommend for each country to MDSR, maternal death surveillance and response. But according to the data, to the report from the UNPFA, it said that Indonesia had a lack of national death review committee because in Indonesia, just like Dr. Deti said earlier, the committee audit is only in the district or city level, and there is also no existence of national MDSR plan. And reliable data for the maternal mortality and its causes, I think it is really important to be an insight to advise the policymaker to make the regulation that could effectively reduce the maternal mortality in this country. Next. Okay, and here is my research question. What are the trends and causes of maternal mortality in Indonesia? Next. And we have two objectives here. First, to analyze and to describe the national and regional maternal mortality ratio in Indonesia and report the trends. And the second is to identify and describe the underlying causes of maternal death in Indonesia. Next. Okay, for the methods, we are using PRISMA guidelines as a standardized reporting items for this SR, and we already registered our study protocol in the Prospero. And for all the steps of the systematic review, we almost complete the systematic review. The next step we have to do now is to up for the result and discussion, and then waiting for the final report. Next. And here is our eligibility criteria. We include study if it reported the maternal mortality ratio on national or regional level, or it could be in the district level or provincial level or in the hospital level, and or report underlying causes of maternal death, and there is no time limit for the publication date. And we exclude study if it is late maternal death, it is primary data is not available, for example, articles from the conference or another systematic review. And if it is case report or case series with case less than 10 and using language other than Bahasa and English. Next. We developed strategy within the team and already consulted with the librarian in the UGM. We using Maelstrom for the maternal mortality in Indonesia, and we execute those such strategy to some major journal databases like PubMed, Global Health, Embase, China, and Coherent Library, and to assure that we cover all relevant study that, for example, published in Indonesia or using Bahasa Indonesia. We also did searching in the Portal Garuda Indonesian Journal Database and Google Scholar as well of using English and Bahasa Indonesia keyword. Next. Okay, for the screening process, two independent authors did the screening. And we are using Mendeley as the reference manager and for the compiling all the articles that we got. And then we use Ryan for the abstract and title screening, and also for the full text screening. Next. Okay, for the quality assessment. Two author also did the quality appraisal separately, and we use two tools here. First is for cross-sectional quantitative and retrospective studies. We are using Axis tool, and for the case control and case series, we use GBI appraisal tool from the Johannesburg Institute. Next. Okay, here is the result. As you can see in this Prisma diagram, we got total 3,426 articles, and after they duplicated and reduced in the screening process, we finally got 60 studies included, and it consists 33 studies contain MMR and cause of death, 22 studies contain only cause of death, and 5 studies contain only MMR. Next. Okay, here is the distribution of our included studies. As you can see it, we separate Indonesia into 5 regions. First is Sumatra, and then Kalimantan, Java and Bali, Sulawesi, and eastern part of Indonesia. And as you can see here, most of the studies that we found is conducted in this region, Java and Bali. And we have 6 studies that have national level. Next. Okay, here is the characteristic of our included study for study design. Most of our study that we found is using study design, cross-sectional, descriptive, quantitative, descriptive, retrospective, and case control. And just like I said earlier, most of it, 65% conducted in Java and Bali, and for the study setting, 50%, 58% of them, or 35 is using community-based. Next. Okay, here is the result for the maternal mortality ratio. This table is like compilation from 38 studies that we found. And as you can see here, only Java and Bali region who has full data for each time period. And for the rest of the region, there is some blank spaces because we didn't find any articles that region for the certain time period. But from here, we can still see the pattern of the maternal mortality ratio in Indonesia. As you can see, in the Java and Bali region, the trend is going down from 766 in the 1990 or before that to become 125 in the time period 2016 until 2020. And it also happened in Sumatra and eastern region of Indonesia. But on Sulawesi, we only found time period, so we can see the trend. And for the Kalimantan, it seems like the trend is going up, but unfortunately, it's because we lack of number of studies that conducted in those regions. Next. And here is the pattern of maternal mortality based on our result. We can see here, the trend is a pretty downtrend from 450 in the 1990 or before that to become 200 in the time period 2006 until 2010. But from this point, it goes up slightly to become 248 in the time period 2016 until 20. And if we compare our result with the data from the Statistical Bureau of Indonesia, we can see in this graph above, the trend is quite similar with this data, even though the exact number is a bit different. The trend is still pretty the same. It's going down, but in some point in 2007, it rises up a bit. And in the graph below, you can see that from the data from the Minister of Health of Indonesia, the number of cases of maternal death in Indonesia from 2018 until 2021 is going up, and the peak is in 20 and 21, with the case almost 2 times if we compare with the previous year, and it is due to the COVID-19 pandemic. Next. And here is the graph for the underlying cause of death. This graph come from 55 studies, 33 studies which contain MMR and cause of death, and 22 studies that only contain cause of death. And the total maternal death which has information about the cause of death is 11,136. And we did the grouping, and we did grouping those cause of death into 8 category based on the ICD-MM. And in this graph, we can see that the top underlying cause of death in Indonesia is obstetric hemorrhage with 25%, and then followed by hypertensive disorder around 24.4%, and the third is indirect cause of death around slightly lower, 23.9%, and there's still a lot of number for the cause of death, and the rest of the underlying cause of death is still a few, like other obstetric complication for 8.4%, pregnancy-related infection around 5.7%, pregnancy with abortive outcome around 2%. Next, please. Okay, the slide is a bit messed up, maybe because it's shown from another computer. From here, we can see that for the obstetric hemorrhage, most of the case come from hemorrhage in the partum and postpartum period, and for the hypertensive disorder, most of it comes from preeclampsia and eclampsia, around 67%, followed by hypertension. And from non-obstetric complication, 59% come from other maternal disease, followed by maternal infectious disease. So maternal infectious disease still have like quite number in here, and followed by pre-existing hypertension. And for the other obstetric complication related partum, around 43%, obstetric embolism around 13%, and followed by long labor around. And for the infection, most of it come from purpular sepsis and unspecified sepsis or infection. And for the pregnancy with abortive outcome, 57% of them come from abortion, and 43% of them come from ectopic pregnancy. Next. Okay, here is the elaboration from the indirect cause of death. As you can see here, for other maternal disease of the circulatory system, like is still quite many, followed by pulmonary disease, dyspepsia, and asthma. And for the maternal infectious disease, some infectious disease like tuberculosis, HIV, hepatitis still be a problem in here. And the last is pre-existing hypertension, around 11%, and diabetes mellitus in pregnancy around 0.2%. But this percentage using denominator from all the cases that we got, those that 11,000, not from this number. Okay, next. Okay, so first of the studies conducted in regional Java and Bali, and there is big difference in MMR between region, and as you can see in the result, the trend is going down, but in the time period around 2006 until 2010, it has up a bit. And most of the internal most of the maternal death is due to the obstetric hemorrhage, hypertensive disorder, and indirect cause of death or non-obstetric Next. And here is our future research that we will conduct it in the future. First, we want to describe characteristic causes and risk indicators of maternal and mortality and morbidity in Jakarta. We also want to know the effect of the COVID-19 pandemic on the maternal mortality in Indonesia. And we also want to evaluate the quality of antenatal care in Jakarta. And the last is to assess the health information on health in Jakarta. Next. Thank you so much. And I also, thanks to the Department of Obstetrics, UMC Utrecht, and the Global Health Support Program for the opportunity for me to being a PhD in there and for the scholarship that they provide for me. Thank you so much for your attention.
Thank you, Aji, for the really nice work you did already. And it's impressive as the numbers you showed, and also Dr. Detti. I was just on the WhatsApp together with Nas, the next speaker, that it's amazing how high the numbers are. And it would be really interesting to see more in depth, like what are the cases of obstetric hemorrhage, and what can we learn from each other? Because in the Netherlands, we almost don't see any cases of maternal deaths due to obstetric hemorrhage anymore. But I would want to give the floor to Athanasios Kalianidis. And he is at the moment a resident in obstetrics and gynecology at the Leiden University Medical Center. And as you can see, he's now in theater. And we have to speed up because I think one of the operations will start soon. And as I said before, he will defend his PhD in March next year. And there will be also a symposium at that time. But we will share the details from that. But Nas, please, the floor is yours.
Thank you very much, Kitty, for giving me this opportunity to show our work of the Dutch Maternal Mortality Committee. So, being short of time, I will keep a shorter presentation. Maybe first a little view of the Netherlands. We are a high-income country in the far west of Europe. And we have a very small population compared to Indonesia with only 17 million people. And within almost 100 hospitals which provide obstetric care, the Netherlands has a yearly amount of almost 160,000 births with a cesarean section rate of 17%, which is very low even within Europe and also I think worldwide. It's a quite neat percentage of cesarean sections. And very unique to the Netherlands is also the fact that we have primary care also within obstetrics. So low-risk pregnancies and healthy pregnant women can be under midwife-led care. The Netherlands is a high-income country and we have a fairly low fertility rate with around 1.7 births per woman. So, in contrast to Indonesia, for us to get numbers to report on, it takes us many years. And here you can see the numbers between 2006 and 2020. And you see on the left, the numbers up to 1 year postpartum. And you can see this is almost 200 maternal deaths being reported in this 15-year period. You can also see that still the most of these deaths are due to direct causes of death. And when you look up to 6 weeks postpartum, which is the 40-day interval, we had a little bit more than 150 deaths, which makes the maternal mortality ratio being at 6.1, which is also one of the lowest within high-income countries. Then with all the data we have, we can analyze the characteristics of the women, but I will show you only a few of them, which are interesting. Typical of the Netherlands, as I told you before, is the midwife-led care. And you can see that half of all women that eventually died started their pregnancy at the midwife practice. This means that these were healthy women previously with no risk factors and nothing that could tell us on forehand that these women would have such a terrible outcome of this pregnancy. 40% of women started their pregnancy, had the pregnancy intake within a hospital at an obstetrician practice, which means that they had at least some kinds of risk factors or making their pregnancy a high-risk pregnancy. We also saw that the place of birth at 1 out of 10 women was at home, which is lower than the average within the Netherlands, which is about 15%, and 82% of the women gave birth in the hospital. This doesn't mean that it was the eventual place of death, because a lot of the women who gave birth at home died later in the hospital or at other reasons of death. So the place of birth was not related to the cause of death and not even to the place which they finally died. Well, how did this woman give birth? We saw that half of the reported cases, half of the reported women had cesarean section. This is, of course, due to their being at high risk. We know that the women that have multiple complications are more likely to have cesarean section. But it's especially these women who also experience complications of the cesarean sections. And we know of research that at least in 1 out of 10 women, the cesarean section, at least to some degree, influenced the train of events that eventually led to the death of the woman. The other half of the women had vaginal birth, and 7% of them had assisted vaginal birth, which in the Netherlands usually means they had a vacuum extractions, as we don't do any more forceps in the Netherlands. We know also that women who we also look into the risk factors, and we saw that compared to we looked into ethnic backgrounds, and we saw that compared to the native Dutch women who were born and raised in the Netherlands, women with a non-Western ethnic background had a 1.6 times higher risk of death. And within this group, women from the Dutch Antilles had a 3 times higher risk of death, which is very striking because these women are second or third generation in the Netherlands. They speak the language, they have access to healthcare, they have access to health insurance. So access should not be the problem, but still they lag behind in outcomes compared to their to native women. So we have to better understand in the future why this is so. Is this something in their genetics or epigenetics, or is this still something that has to do with perception of illness, or still some barriers that they experience to access healthcare? Kitty told you already something about the causes of death. For the first time in history, we saw that cardiac diseases as the cause of death #1 in the Netherlands. And due to better care, hypertensive disorders now is only the third main cause of death in the Netherlands after thrombosis. And it was also very striking to see, if you see blue with orange is also the late deaths, that if you look up to 1 year postpartum, suicides were the second most important cause of death, because women with psychiatric disorders might undergo suicide later after 6 weeks postpartum, and it's important to realize that. So from the audit that we perform on every case with looking into all the medical cases, we try to make lessons learned and to see what can we learn from these women so that we are able to prevent women from dying from the same causes or same maybe mistakes in the future. So first of all, we understand now that the better care for the hypertensive disorders leads to a decrease in this cause of death. We have stricter blood pressure management. We treat earlier with magnesium sulfate and induce labor earlier. Also, we have seen that maternal mortality and morbidity is not only the problem of the obstetrician. We are faced with many women with cardiac diseases, neurological diseases, and psychiatric diseases. So you really have to have a multidisciplinary team, a good obstetric anesthesiologist to take care of the higher numbers of high complex women we are faced with. And with the new data, with psychiatric disorders being second most important cause of death up to 1 year, there are a lot of activities being undertaken to recognize this woman in an early phase and to give them support to try to prevent the escalation of their disorder. Sorry. So I would like to thank you all that I'm given the opportunity on behalf of the whole Dutch Audit Committee. And if you want to read more, you can find our article on PubMed, which has been published. Thank you very much.
Thank you, Nas, for your really nice presentation. And I think we have still 7 minutes left to discuss a little bit about the work we have showed. Until now, I didn't see any questions in the chat function. So if the audience has any questions, please put them on the chat. I think myself, no, it would be a question. Dr. Detti and Nas and Aji, what do you think would be a step we could do as Indonesia and the Netherlands to improve it for the Netherlands and Indonesia? Who wants to start? Dr. Detti?
Yes, thank you, Kitty. Yeah, I think it's very interesting. Listen to your presentation, also Nas' presentation. It inspiring us that we have to work hard, to together to reduce our maternal mortality rate. Yeah. So one thing I think we could sit together with the Ministry of Health in our country, and also maybe we could say we could sampling to, for example, two province, our province, Jogja province, which actually we have low mortality rate compared to other province in Indonesia. And we can choose another province which has higher maternal mortality rate, which is Central Java. So we can have like compare study about the maternal death review in our two province with Netherlands, something like that. So we can learn from you, of course.
Yeah. Nas?
Yeah, this is a very interesting question. I think we can all learn from each other. You were faced with enormous numbers, which you managed to review. So I think it will be interesting to join the committees together and maybe try to make a review of some cases to see the differences between the review systems and the way that we look into the cases. And it would also be interesting if some part of Indonesia could also join the INOS platform system to also enlarge in our reach of coverage of maternal morbidity research that is being done worldwide. Because I think Indonesia has a lot to learn us in how the management of these numbers are being done.
And Aji, what are your thoughts?
Yes, I agree with Dr. Detti and Nas. I think it will be like amazing if we can, like, for example, exchange the case for each country, and try to know how each country identify the cause of death and how they defined the 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 underlying causes. For example, like what you did with the Netherlands and UK. So we can also can try to do it between Indonesia and the Netherlands, and Yogyakarta as the sample.
Yeah. I completely agree with all of you, and I think maybe that's a nice conclusion of today. There are things we can learn from each other. We all do it in our own countries already, but probably when we come together with the committees together, and we need some funding or whatever, but maybe the governments can help us out. And I do see here in the Winner platform already some people reaching out to me, and maybe we can ask them to help us. We did it actually from the Netherlands together with the UK and with France, and it did help to see there is a difference sometimes in the classification, and one of them is published in the Lancet. Where does the chain of events start? For instance, when you die because of postpartum hemorrhage while you have had preeclampsia, how do you classify it? So you know you can compare. So that's one thing. The other thing is it's really interesting, but that needs a lot of work to translate the cases in Indonesia and into Dutch, and then discuss the cases in detail, because you can really learn from each other as a review committee. The suggestion to join INOS, that would be good, but also with the maternal mortality, because there will be, and that's good to hear, I think, very soon a report in the BMG about the INOS maternal mortality rates and causes of death. And we are lacking low and middle income countries. So that's nice I think, to join as well. And you have really nice regional data. And the other thing I was very interested in is in your online system of reviewing, because actually, and we didn't present, we have also a kind of online review system, which is the DAS, the Delphi audit system. And we just tried it out, where you do it in a systematic way. But it would be nice to compare those two systems, and other countries could use it as well, because I know very often we don't have enough time, and we learned from the pandemic that online a lot of things are possible. So maybe that could be an option as well. When I see the time, I think then I would like to thank all the speakers. Thank you so much for all your time and effort and all the work, because I do know the registration and the audit, it's a lot of work. But I really would like to thank the organizers of Winner and all the people who are making this possible, but also our technical support during this meeting. So that's really nice for everything. And I hope we can, through this session, reach out more to the whole community who's involved in Indonesia and the Netherlands. And we want to improve the health of the mothers and decrease maternal mortality. Thank you.
Thank you.
Okay.
Bye.
Thank you all. Bye.
Thank you.